It is my pleasure to welcome Dr. Kumbani, a professor of medicine and the section chief and director of interventional cardiology at UT Southwestern. Today, we'll be discussing his JACC interventions manuscript investigating hospital volumes and outcomes of TAVR and mitral edge-to-edge repair in the contemporary era. Dr. Kumbani, thank you so much for taking the time to join us and share your expertise.
Yeah, thanks so much for having me.
First, can you give us a background about the topic, the questions that you aim to answer, and the population that was studied?
Yeah, so for this particular analysis, we wanted to understand what the correlation is for from a volume standpoint as well as from an outcome standpoint for procedures that are broadly considered under the structural heart intervention umbrella. And so we're looking at specifically at TAVRs and transcatheter edge-to-edge repair, as you mentioned. And so, what we really wanted to understand is, what is the hospital level correlation in the volumes as well as the outcomes for these procedures. And for this purpose, we, tried to use the STS-ACC TVT registry, which is one of the largest international registries, one of the largest registries anywhere that really has very granular data on both of these procedures.
And then kind of starting broadly in terms of volume, was there a correlation with, the volumes of TAVR and mitral edge-to-edge between these centers and hospitals?
Yeah, so, we included data from 2013 to 2022. So, we included, pretty large sort of volume of patients, almost 400,000 TAVRs and 53,000 plus mitral edge-to-edge repair. So one thing, speaking about volumes, so, the median volumes from a TAVR standpoint were pretty high across the country. They were, about 94. But for mitral edge-to-edge repair, the volumes are still pretty low, relatively speaking, only about 19. And what we noted is there was a modest association between volumes at the same hospital for these two procedures. So we noted a correlation coefficient of about 0.5. So that's, sort of modest correlation, suggesting that it's reasonably likely that a high volume TAVR site would also be a high volume mitral edge-to-edge repair site.
And kind of talking about outcomes of these different procedure kind of separately, was there a trend toward improved outcomes of each of these procedures with the higher volume centers?
Yeah, so there have been a number of studies looking at the relationship across the same procedure or for the same procedure. And so we also noticed that in general for TAVR separately and then for MTEER separately, there was sort of this correlation with, in hospital as well as 30-day outcomes individually for these procedures, such that, if it was a negative association, meaning the higher the volume, the lower the complication risk. Now, one thing I will note compared with prior analyses on this topic, the absolute differences, especially for TAVR, were pretty small.
Okay. And what about kind of putting both of these procedures together? Was there a correlation, between the outcomes of TEER depending on the outcomes of TAVR?
Yeah, so, this was probably the most surprising part of the whole analysis in that, we found, so what we did is, we looked at it a few different ways, but I think the one that seemed to be the best way to analyze these data were to use deciles of risk-adjusted outcomes. And so, as I mentioned, we looked at both in-hospital as well as 30-day outcomes. And, obviously, these are different procedures, different populations. And so by using sort of this decile approach, where you're ranking them based on how they've done for that individual procedure, I think it takes away sort of comparing absolute numbers between the two procedures. And we actually noted a significant discordance between the two procedures in that, if you looked at a hospital that was in the, let's say, the top decile for one of them, there was only about 15% likelihood that they would also be in the top decile for the other procedure. And so the decile concordance was only about 15%, and only about half the centers were within sort of 2 deciles, performance deciles of each other. And more than, and what we noted is more than 35%, there was a significant discordance. So they would be very high for one, but very low for the other. And then we looked at this in terciles as well. And again, something very similar, that there was, a fair amount of discordance between the two procedures as far as outcomes are concerned.
Interesting. And kind of from your perspective, how do we move forward with these results, especially in the context of centers of excellence with the structural interventions and all of this?
Yeah, that's an excellent question. And we've been kind of thinking about this as well. So, the centers of excellence from a valve standpoint, has been endorsed both, from a societal standpoint, as well as, from a health system standpoint. And, there is sort of this implicit belief that, if you're good with, aortic procedures, for example, that you would be equally good for mitral procedures. And, we had done an earlier analysis looking at this on the surgical side, and this is sort of an extension of those findings on the transcatheter side. And, we clearly see that there's a discordance that you could, be the best center or in the top performing centers for one, but not for the other. So for us, I think, it suggests that we need to do a little bit more of a deeper dive into the centers of excellence concept, sort of really trying to understand, what factors may be overlapping, which of those are, not overlapping, and then so accordingly, how would you phenotype them, and perhaps structure care pathways accordingly. The other part of this, I think, two other things I'll say. One is, this clearly has a bearing on training programs, because I think, again, the higher volume, the busier centers tend to be, places where, structural fellowships are usually housed. And so, this, there is a, one of the reviewers had brought this up, and we mentioned this in the manuscript, that, should we consider sort of the mitral edge-to-edge repair as a, separate discipline within structural heart interventions, and should there be sort of a different training pathway that needs to be considered for that? And the second thing is, also trying to understand this a bit more on a deeper way, how much of this is driven by sort of what I would call structural factors related to the hospital, versus how much of this is driven by the operators. Because, many hospitals, as have separate teams for aortic and mitral procedures. And so I think, there's a lot of things we still need to understand about this.
Yeah, and I agree. It's very interesting results. And as you mentioned, it kind of probably pushes back to look at the definition of, centers of excellence and maybe take a deeper look. But, thank you so much for sharing your expertise, Dr. Kumbani. And I invite everyone to read the full manuscript published in this issue of JACC Interventions. Thank you again.
Thank you.